Uh, okay, I know I'm standing between you and dinner, so I try to make it as painless as possible. Before I start, I want to thank the Society for extending invitation to me. Professor Tong, the president of the society, Professor Zhang, the chair of the Uni Radiology Department, and also specifically the secretary of the society who helped me a lot with the processing of my visa in a few hours yesterday. Otherwise, I couldn't make it. So, having said that, um, let me just. I have a double background, radiology and nuclear medicine, and I'm biased, and I'm very biased for both of them. So, just make it very simple. This is our matrix when you want to compare, for example, a PET with MRI. So if both of them are positive, if the PET is positive and MR is positive, most likely it's a tumor. If PET is negative and MR is negative, most likely the case is negative, patient doesn't have any. Well, there are exceptions to both of them, of course. And of course, when the MR is positive and PET is negative, so it can be potentially a false positive of MR or false negative of PET. And then, well, the reverse is also true. When the MR is negative and PET is positive, it's either false positive of PET or false negative of MR. Now, having said that, not everything falls into these categories. Some of these are actually right in the middle, somewhere here, which I'm going to show you cases, case after case after case, and I let you judge which one you're going to go for. So there are inherent problem with both modalities, with MR and the PET. Both of them are excellent, but there are also shortcomings. Um, most of them, if you want to basically simplify it into two categories of the problem, number one is a resolution, number two is a mechanism of the demonstration of abnormality. As you know, in PET, we use molecular markers, and in MR, we usually use anatomical or morphological markers. And also the resolution of these two modalities are different. Although the PET is getting better and better, as one of the probably the first whole body PET in the world was was invented at University of California, Davis, and the resolution is actually very, very good. Now, having said these, let me start showing you a few cases. Now, let's start with this case, for example. MR shows some abnormality in this location. PET also shows a little of activity here. This patient had a history of cervical cancer that turned out to be FDG activity in a sigmoid diverticulum. So it was like false positive of MR. Now, take a look at this case. This is a post-therapy case of the post-radiation therapy of a tumor. As you see here on the MR, it shows a little of edema. Is this positive or negative? You do a PET scan, you don't see any activity in this location. So it turns out that it was the false positive because of the radiation, because of the edema in the cervix. So in this case, PET is a winner. And take a look at this one. So there's this abnormality in the pelvis, and you see this focus of activity on the FTG study, which corresponds to this abnormality that you see on the MR. So this is one of those cases that actually MR can clarify what the problem was. This patient has rectovaginal fistula, and in the wall of the fistula, we know can be tumor or can be inflammation. And in this case, this was inflammation. So this was actually considered false positive of the PET scan. Now, take a look at this one. This is a concordance. You see this cervical mass on the MR, which corresponds to the positive FTG activity on the PET scan. So this was a concordance. Both of them were correct. This patient had cancer. And take a look at this one on the MR and the PET. It's also another correlation. So on the MR, you can see these lymph nodes, pelvic sidewall lymph nodes, which corresponds to this focus of activity on the FTG study. So this was a concordance of the both of them are positive. So what is MR good for? So in MR, and it's true for, that's what I do. I'm an oncology imager. I do multimodality oncology imaging for the past 25 years. So in general, MR is used for N staging and M staging, nodal staging and metastasis staging. Because PET. PET is the top to toe modality. So this way, anywhere in the body, if there's any abnormality, you can kind of find it on the MR. On the PET. MR mostly is used for locoregional evaluation for T staging or N staging. Okay, so this is just a general guideline. Take a look at this one. On the FTG study, there's this tiny focus of activity that corresponds to this lymph node in the left paraortic chain. Now, by MR criteria or CT criteria, this is not an abnormal because the shortest diameter of this tumor is less than 1 centimeter. So if I'm going to read only the CT or MR of this case, I'm not going to call it positive because it's less than 1 centimeter. That's our magic number. But on the FTG study, it shows activity. So one of the reasons that this was negative because of the resolution. This is micrometastasis into the lymph node that usually MRI and the CT, they miss, and you can pick it up on the FTG study. Take a look at take a look at this case. This is a case of concordance of the MR and the PET. The patient has an ovarian cancer, and as you see on the DW images, you see this activity which corresponds to FTG activity on the PET scan. So in general, MR is for locoregional staging. PET is for systemic staging. This is another case. This another case. As you see, there's this activity in the retroperitoneum. This is a patient with endometrial cancer, now have a recurrence, and on the DWI images, you can see these lymph nodes, which is normal size, but it shows a restriction on DWI images. I very much like to look at the DWI as a PET version of the MRI, although the mechanisms are totally different, but they kind of look alike. Whenever I want to compare the PET to the MR, I usually compare with the DWI. So, and then in this case, this patient has a very tiny abnormality here in the segment 7 of the right lobe of the liver, which corresponds to this focus of activity on the nuclear medicine scan, on the FTG scan. So on the liver, if somebody show me this MR, I have no idea what this is. It can be a small cyst, can be small hemangioma, can be anything basically. Yes, it can be tumor too, but on the FTG, it shows activity. It tells you that this is tumor. So this helps also with characterization. It's not a matter of detection. It's also a matter of characterization. Although both modalities detected, PET gave you the characterization. MR didn't give you the characterization. So detection and characterization are two different animals. So there are, just be very quick on this. There are a lot of different radio tracers that we use for the oncology imaging, and these are a bunch of these. Most of them are actually clinically available these days. But for the convenience, let's stick with the FTG for the time being, because FTG is kind of available in every country, in every institution. So in the remaining of this talk, I want to walk you through specific organs in the gynecological oncology. Let's start with the uterus. So, and this is the case, and all of these are difficult, like problem cases. So I want to look at the PET, I want you to look at the MR or CT, and then compare them side by side. At the end of this lecture, you have to decide which modality has which strength. The bottom line gonna be you have to know the weakness and strength of each modality and put all the information together and then draw your own conclusion. Take a look at this this area. This is the urinary bladder, and you don't see any abnormality in this area. And the reason for that is because urinary bladder is so distended that obscures all the foci of activity around it. And that's very important because when you empty the bladder a little bit, then you start realizing there was something here in the posterior aspect of the bladder. And then when you look at the MR, now MR can be explained. So this focus of abnormality that you see on the MR is actually corresponding to this. So if you don't do it the right way, if the lesion is next to the urinary bladder, do not use a full bladder. You're going to miss it on the FDG. So make sure that you empty the bladder, especially if you put a catheter and empty the bladder, you're going to see these foci of abnormality much, much better. So this is a pitfall. Take a look at them. Yeah. Okay. Next case, I want to show you endometrial cancer. Well, in general, evaluation of the endometrium is very difficult by the MR and on the PET for the small lesions. Big lesions, no problem. But when it's a small lesion, so for example, you look at this area, you cannot really see any lesion. But on FDG study, it shows some abnormality here. And the rest of the endometrium also shows activity. Well, this patient had a follow-up ultrasound after a few months, and they were normal. So this turned out to be hypertrophy of endometrium due to tamoxifen. So whenever patients on tamoxifen, that's usually a problem because you have hyperplasia of the endometrium, they can have endometrial cysts. On the top of that, they can be very hypermetabolic on FDG. Therefore, interpretation of these cases are difficult on both CT and MR. I'm sorry, on PET and MR. Take a look at this case. This is the patient, another case with endometrial cancer, post the total abdominal hysterectomy. On the MR, you see this abnormality, which corresponds to focus of activity on the PET images. This was a case of the recurrence. Both MR and PET, they showed you the same finding. This is the case that I showed you before. This lymph node here in the retroperitoneum using CT criteria is not very abnormal, but on the FDG study it shows activity, therefore it is abnormal. Take a look at this case. This is for the total abdominal, basically abdominal staging. Omental caking here, the haziness of the mesentery, nodular appearance of the mesentery, you can see it. That corresponds to all these abnormalities you see on the PET scan. Now pay attention to the surface of the liver. You can't really pinpoint anything here, but when you look at the PET actually shows all these small hypermetabolic nodules over the surface of the liver. Over the surface of the liver and over the surface of the spleen, these are the two areas that you specifically need to look into that in patients with ovarian cancer or peritoneal carcinomatosis. And it's very important, but most of the time, if they're small, we miss them on the CT and on MR. But PET usually picks them up, and this is just an example signifying that the CT was kind of negative and then PET was positive. Cervical cancer, well, cervical cancer, PET, we usually use PET when the lesion is big and when you want to do top-to-toe staging. As you see in this case, this patient has a lung metastasis corresponding to this lung nodule to see activity, got lymph nodes higher up in the supraclavicular region. And then lower in the retroperitoneum, you have lymph nodes, and also this is a primary tumor, the cervical tumor. And what you see here is basically obstruction of the cervix with distension of the endometrium full of blood and debris. So this was a case of cervical cancer. As you see, MR and PET, they have complementary function. Take a look at this one. This is another example that when you put them side by side, finding these little nodules is usually difficult by MR. CT is better, of course, but when you do a FDG study, clearly you can see these activities, and you can do the top-to-toe staging for these cases. Another case of cervical cancer, as you see here, the primary tumor is located here. Difficult to see, but on the PET images, you can kind of clearly see. Also remember, on the PET scan, you may see a lot of abnormality on the MRI. But on the PET scan, when it shows certain point of activity, if you want to biopsy, you need to biopsy that area, not everywhere else. We call it PET-guided biopsy, basically. So if you want to biopsy, you want to biopsy exactly this location, not here, not here. Although on the MR, usually a wider area shows abnormality. And this patient, of course, has metastases to the ovaries, as you see here. This patient has corpus. It is important to look into the morphology on the MR because, for example, corpus luteum can be easily differentiated on the MR, and on the PET, they're positive. So this is one of those things that MR can clarify to better characterize the abnormality that you see on the PET images. Another example of the cervical cancer. This patient has all these little lymph nodes here that usually don't report them because they're small. But as you see here, this patient has metabolic activity in all of those lymph nodes. Therefore, therefore, MR is underestimating the extent of the disease, and PET is making the correct diagnosis. This is just another example of that. That this is a false positive of FDG. This patient has this focus of activity here on the MR. It shows a normal ovary. Sometimes these tumors are really big and heterogeneous, and it is difficult to, especially if they are close to the bladder, it's difficult to make the differentiation on the FDG. I have no idea if this thing is invading the urinary bladder or not. But on the PET portion of the study or CT portion of the study, you can clearly see that this tumor is invading into the bladder. So in this case, MR can clarify issues. Now, next topic is ovarian cancer. Ovarian cancer is a big topic, and we have all these different criteria for this, the ultrasound and CT and MR, and we have ORADs, which is another system to like a BIRAD, another system for staging of the guide us through the classification. FDG, however, was not introduced into the ORAD yet. I think that's something that in future that need to be incorporated. As you know, for example, in LIRADs for the liver, finally it's for the CT and MR, but eventually ultrasound got into that. So ultrasound is a criteria for LIRAD. I think here PET will also get into that. So in this case, this patient has multiple metastases everywhere. And this is a primary tumor here, as you see, and it shows FDG activity, of course. And on this one, as you see here, this is another case. This patient has omental caking. This is a very good correlation between the finding that you see on the MR and the FDG activity that you see on the PET scan. Also, this patient has metastasis, malignancy in both ovaries. Evaluation of the abdominal wall sometimes difficult by MR, but FDG can actually pinpoint it. Also remember, inflammation is usually positive on FDG. So if you have endometrioma in the anterior abdominal wall, which occasionally happens, not often, but occasionally happens, they are FDG positive. So keep that in mind that there are false positives related to inflammation when you talk about FDG. This is another example of that. As you see here, the evaluation of the surface of the liver is very difficult using cross-sectional imaging, especially if those lesions are small. But on the FDG study, you can see the activity. This is another example correlation between the MR and PET. Usually, you see these two focus of activity, and if you follow it on the coronal That can be ureter, but in this case, the patient has Krukenberg tumor in the posterior cul-de-sac. And this one has actually a loculated ascites in this location. And there's no, on the MR, it's very difficult to make that diagnosis. So you see the finding, no idea what that is. So you see the CT scan, well, it's questionable. But when you do the FDG study, there's no activity. In this case, PET can clarify, can characterize the abnormality that otherwise we cannot make a diagnosis on the CT or MR. So the last one I want to show you is some malignancies of the vagina and vulva. In this case, most of these lesions, if they're screening, they're actually missed, especially if they're small. And I confess I missed a few of these when they are very, very small, but on the FDG, nobody would miss this one. This patient also has normal-sized lymph nodes in the inguinal region, which otherwise we would not call it on the MR, but on the FDG study, you can clearly see these abnormalities here. Okay. And this is another case. This patient has vulvar cancer, and as you see here, on the MR, there's abnormality, and on the FDG study, there's a good correlation between these two. So areas that are hard to see on the, hard to evaluate on the MR can easily be evaluated on FDG, because there you have like, basically a hot spot is a bad, as simple as that. So this is the case of the patient has a fistula in the lateral wall. In the lateral wall, this patient has rectovaginal fistula, and you see this focus of activity, which makes it a malignant one. I'm not going to get, always pay attention when you're reading the FDG cases for gynecological malignancies, pay attention to other structures. And one of the important ones is rectal cancer. This patient has abnormality, has a GYN malignancy. On the top of that, has a rectal cancer. And the rectal cancer also shows up on the FDG scan. As a matter of fact, every case in my institution, every rectal cancer case in my institution gets the MR and FDG study for the initial staging. This is, so as a conclusion, we have to know, whenever we read these cases, we have to have a good understanding of all the shortcomings, strengths of each modality. PET and MR, which one is better? We don't know. Both of them are great. Both of them are top of the line modalities that we have. However, they're complementing each other, so they're not really competing. They're just adding to each other. In general, for locoregional staging, MR and PET are kind of same, but MR maybe is a little bit better than PET, but for the systemic staging, we use PET. Thank you very much for your attention, and thank you very much for having me here in Da Nang. For the next 2 weeks, we're going to have a visiting professorship at VSRNM University, so we're going to have daily morning sessions, and then we have a noon conference every day, and then we're going to have a symposium on Friday on fetal MR. This is a book that we wrote, and most likely next week, Friday, I'm going to give this conference. For any of them, for additional information, you can ask Professor Zhang, who is the chair of the VSRNM University. Thank you.